Thank you, Fran. So yeah, I'm Will Alazawi. I'm a liver doctor, and I study the liver, and I look after people with liver disease. And I think one of the things that comes across is that a lot of my patients are always asking me about what their liver is. And one of the most interesting things that I find is where people point to when they come into the room and they tell me that they think they've got a problem with their liver. So I'm going to ask everyone to point to their liver. Point to your liver. I mean, it's amazing how different we all are. The diversity of where we've all got our livers, it's amazing. So I'm going to talk about the liver. I'm going to talk to you a little bit about where it is first. I think we'll start with that. I'm going to talk to you about what it does and then what happens when it goes wrong. Okay, and that's really where my research is focused on. So that's where it is. It's a pretty big organ, the largest internal organ. It weighs around, well, depends on your size, but between 1 and maybe 1.4 kilos. And most of it is under the rib cage on the right-hand side. Okay? So you shouldn't be able to feel it in the squidgy bit of your tummy. It's all protected by the ribs. And liver disease really matters because over the last 40, maybe 50 years, while everybody else has got really good at looking after people with their conditions, whether it's heart disease, diabetes, cancers, lung disease, actually the rate of rise of deaths from liver disease has rocketed, okay? And it's completely out of keeping with the rest of medicine. So either we're terrible doctors or there's something else going on. Well, you can decide that. In order to understand what the liver does, actually understanding what it's next to is really important. And the liver is really close to the gallbladder, the pancreas gland, and the digestive tract. And hopefully that already gives you a flavour of the sort of thing the liver should be doing. And when you've got this great big brown thing in the abdomen, and back in the day when people were less they were a bit more gruesome, all right, and less squeamish, people were really fascinated about what this organ was, in whether it was in the animals that they were killing and eating, or whether each other that they were killing and doing other things too. So people have always been really fascinated by it. So this chap on the right, anyone know who he is? This is Galen, so a 2nd century Greek, sort of Byzantine Greek philosopher, scientist, if you like. And he said that the purpose of the liver was to warm the stomach, okay, and therefore everything that you ate, because it sits right next to it. And about 1,000 years later, this is Ibn Sina, so he's also from the Middle East, so Avicenna is how his name's been anglicised. So Ibn Sina said that the liver was the seat of our nutritive and vegetative functions. I haven't really got a clue what that means, but I think what he's saying is that it's really important and stuff. So people are interested in the liver. So what does the liver really do? So I've already said, I've given you a clue that it's to do with our digestion, but you can get an awful lot more information when you figure out where the blood going to it comes from. So generally speaking, the organs in the body get their blood supply. They get nice, fresh, oxygenated blood that comes really close to where the heart has just received it from the lungs, and that's what the organ needs to function. The liver is very, very different. Okay? That accounts for maybe 10, 15% of the blood that the liver gets. The rest of the blood that the liver receives has already gone through your gut. And all of your gut. So you can see here this great big blue vein there. That's called the portal vein. And that vein carries blood from the stomach, the small bowel, and the large bowel. Now, what that really means is that everything that goes in your top end and is absorbed into your body must, because that's how you're plumbed, no matter where your liver sits individually, the way you're plumbed means that that stuff has to go to the liver first. And so your liver is effectively the first line of encounter of anything that you eat, drink, take, ingest, whatever word you want to use, imbibe, it all must go through your liver. And actually, Galen wasn't far off, because the liver really does create heat. Okay, a lot of our heat, we're not poikilotherms, although actually you do sometimes see the medical students coming out of the Perrin Lecture Theatre and standing in the sun for a few minutes just to warm up a little bit, and then back they go in. But we're not poikilotherms. We actually generate our own heat, and we generate that heat as a byproduct. And it's a byproduct of the metabolism that the liver undertakes. And that means taking all the nutritional food, all the great stuff that you eat, whether it's carbohydrates, proteins, fats, it all has to go through the liver for the reasons I've said. It goes through complex signaling pathways. Are any of you sixth form students here? Anybody doing biology? Yes, so you'll know all about Krebs cycle, I'm sure you may all have heard of that. Some fantastic stuff for you to write up on your bedroom wall and remember. And that generates the energy. That's the energy that your body needs to survive, but it also creates a bit of heat. So we get energy from our food through what the liver does. The liver also makes the bile, okay, and bile is stored in the gallbladder and then is squeezed into our digestive tract when we eat. So bile is, well, a few years ago we thought that all bile was a bit like fairy liquid. So has anybody ever cooked a roast? Okay, right, so you cook your Sunday roast, you sit down, you spend 3.5 hours cooking it and about 14 minutes eating it, because that's the way it works. And then you take the roasting dish, the roasting pan, and you put it in the sink, and you turn the tap on, and then you just get all this sort of, fatty, scummy stuff floating up to the top. It's pretty grim, right? And if you put a drop of fairy liquid into that water, next time you do it, on Sunday, have a look, and you'll see that all of that scummy stuff on top just dissipates very quickly because you put a detergent in, all right? So stuff that is fat soluble, stuff that's made of fat, doesn't normally dissolve in water, but when you pop some detergent in, it allows the fats to dissolve in the water. And quite a lot of the food that we take in is fat-based, and therefore we need a mechanism to bring that fat into our largely water-based system. And that's what bile does. Now, over the last few years, what we've also discovered is that bile has actually got a lot of signaling molecules in it, and it actually can tell the liver can signal to the gut and tell the gut what to do, and vice versa. And now, there are even drugs targeted against the bile acid signaling pathways. The liver's really important in defense. It's part of our immune system, okay? We all know that there are billions of bacteria, trillions of bacteria that live in the gut. If we have a sort of a freeway connection between the gut and the liver, then we need to have a line of defense to protect us from getting infected from all of those bugs that are in the gut. So the liver's really important in our immune system. It's a factory. It makes pretty much all the proteins, and proteins are basically doing chemicals, the proteins that circulate in the blood. So the proteins that help you clot your blood, that carry drugs around, that carry things like calcium and other ions around in the blood. Really important proteins are made in the liver. And it clears toxins. So it detoxifies the blood. So that already gives you an indication that this is pretty widespread. There are an awful lot of different things that the liver does, and they all happen in the same organ. And that's what makes the liver actually quite complicated, because unlike other organs that tend to have one or two functions, like the lungs, okay, the lungs you breathe in and then elastic recoil does the rest. They don't even have to do too much more than that. Kidneys that are a great big bit of filter paper, or the heart that just pumps things around. This is a lot more interesting. So with that in mind, what happens when the liver gets damaged? What's going on here? Yes.
Prometheus, I changed the rock.
That is Prometheus, exactly. A classical education, you see, it's never wasted. This is Prometheus. Prometheus was a titan, and the reason he's in this predicament is that he stole fire from the gods and taught man how to use fire. And his punishment was that he'd be chained to a rock in the Caucasus Mountains, and every day an eagle would come down and peck out his liver. All right? And every night his liver would grow back, and the eagle would come the next morning, and therefore his torment was sort of placed in perpetuity. Now, either the Greeks had an uncanny knowledge about the potential of the liver to regenerate itself, or this also feeds back into the, well, it's big, it must be interesting. Now, what happens when the liver is damaged? Actually, they're not far off. A lot of the time, the liver can recover, and it can regenerate itself. And in the same way that we have a response to injury, whether it's falling off monkey bars in the park or burning ourselves or getting an infection in our chest, we have a response to that injury, and that's called inflammation. And that inflammatory response works well in the liver, and it can, and sort of if it's a viral infection, the inflammatory response can help us clear a virus along with the immune system, and then if there are sort of dead or damaged cells, it can clear them away and allow the liver to regenerate itself. And that's usually driven by cells that look pretty down a microscope, and this is not a real picture, this is a put together picture, but immune cells that circulate in the blood. So we depend on our immune system a lot, our inflammatory system a lot, to recover from liver injury. So anytime we're doing anything that can damage our liver, it's a combination of the liver's regenerative capacity as well as our immune response that brings us back to a normal state. And the major determinant of how things go tends to be the time period over which that injury has presented itself. So, if someone has an acute viral infection, they eat some contaminated shellfish, let's say, they get infected with hepatitis A virus. This virus can cause severe liver damage. So lots and lots of liver cells get damaged by this virus. The immune system comes in and clears all of those dead and dying cells. During that time period, the patient may become jaundiced, they might become yellow, and they may feel very, very unwell, but by and large, by which I mean more than 90% of people, 95% of people, will just get better. Very rarely, less than 5%, thankfully, of people actually won't get better, because the amount of liver damage will cause so much cell loss that the regenerative capacity is overwhelmed, that patients go into what we call acute liver failure. Now, you'll also know that acute doesn't necessarily mean severe, it just means over a very short space of time. That same picture, other viruses can cause, but can also be caused by things like drug toxicity. So sadly, people who live with depression and can sometimes want to end their lives, and they take a paracetamol overdose, that's exactly what happens. There is overwhelming toxicity of the liver, and that causes acute liver failure. Not in everybody, but in those who do, it can be life-ending. If that damage happens over a longer period of time, and now by definition, the fact that it's a longer period of time means that you haven't succumbed very quickly, but also there's a different set of triggers, a different set of injurious agents, then we talk about chronic liver disease. And that's disease where the liver is slowly being damaged over many, many years. That injury, that inflammation, that recovery is happening repeatedly over years. And by and large, what we see is the liver goes through a series of stages from being a little bit damaged, a bit more damaged, and a bit more damaged again. And ultimately, patients with chronic liver disease are at risk of liver failure or developing liver cancer. So I asked the question, what can go wrong? What happens when the liver is injured? But the liver can be injured and work absolutely fine. The liver can be injured and stop working. I'll give you an analogy. Oh, this is being recorded, so I'm hoping Mrs. Alazawi doesn't actually watch this. But let's imagine, hypothetically, that a few years ago, your spouse may have driven your car over a pile of bricks. Okay, let's imagine that happened. And let's imagine that that took a great big ding out of the side of the driver's door. And let's imagine that you, the owner of the car, think, well, it works all right, I'm not going to spend lots of money to have it repaired. And a few years down the line, the car still works absolutely fine. It's still very damaged, it's still got a dent in it, but it works absolutely fine. And that's what can happen with the liver. So you can have scarring, more scarring, you can even have cirrhosis, but the liver works absolutely fine. So the amount of scarring doesn't necessarily build up to liver failure. There comes a point at which the liver stops working, and that's important to bear in mind because that's different to other organs. So if you get a little bit of lung damage, we can measure things, we can see that the function has gone down. If you get a little bit of kidney damage, again, we can measure that change in function, but that's not possible clinically in the liver. What might happen? I'll warn you now, some of the pictures I'm going to show you are of people who are very, very unwell. These pictures are all in the public domain. So I said that the liver is really important in clearing toxins. So one of those toxins is bilirubin. It's a breakdown product of our red blood cells. The red blood cells that do all the work of carrying oxygen around the blood, they turn over every 90 days. So the bits that are inside that do the work, they need to be recycled. The liver does that. If the liver isn't working, that bilirubin builds up in the skin, in the eyes. You can see it even in the urine, and the patient turns yellow. This is jaundice. Other toxins are toxins that if we don't clear them, things that contain ammonia, if we don't clear them, they can build up in the brain. That can cause all sorts of problems in the brain. Certain cells can swell. More importantly, the brain can stop working. We call that encephalopathy. So a confusion that arises because the liver is no longer clearing the toxins that it needs to clear. When the liver becomes scarred, scar tissue is not as supple as normal healthy tissue. And that scar tissue means that overall the liver becomes stiffer. And given that there's a great big blood supply from the gut, if the liver becomes hard and stiff, then the blood won't flow through it quite so well. Blood is a liquid, and just like water, if anyone's ever had a leak at home, you know that the water has to go somewhere, right? And so if the liver is hard and stiff, then that blood builds up. And it starts to build up in the blood vessels that should be draining the abdomen. And so water is pushed out, and unfortunately, people live with a condition called ascites. And ascites is the buildup of fluid in the abdominal space because there is a problem with the flow of blood through the liver. It's not the only reason. There are other reasons associated with the things that the liver should be doing to maintain proteins in the blood, to maintain the integrity of our blood vessels. But, you know, a person like this may be carrying 20 litres of excess water in their abdomen. That's 20 kilograms. Okay? So these things are really very serious. And once we see this, whereas before I said you could have cirrhosis when the liver was working well, and that's compensated disease, here the liver has started to fail. That blood has to go somewhere, right? If the liver is stiff and it's not flowing through. So it starts to find side channels. Now those side channels, they're not proper blood vessels like the ones we depend on in the rest of our body. These are new, they're formed in a hurry, they're weak, and they're at risk of bleeding. This is an endoscopy view. So this is where a camera, about the size of my little finger, pops over the back of the tongue and slips down into the gullet. And you can look down, and as you see there into the dark yonder, that's basically where the gullet joins the stomach. In a person living with chronic liver disease, you can see that there are now these tortuous, knobbly looking, actually very thin-walled veins in the lower esophagus. So that healthy, smooth lining has now got evidence that there are these new veins. We call this portal hypertension or varices. And unfortunately, these varices are at risk of bleeding, and we see really quite severe bleeding, and this can be life-threatening. And we can treat patients who have liver disease by going down and using endoscopic tools to stop the bleeding. But ultimately, it's the underlying liver disease that's the problem. And when patients whose liver disease has progressed to a point come into hospital and they have decompensated, Over the last few years, what we've done as a specialty is understand the ways in which people's liver starts to fail. Because the liver's got over 500 functions, unsurprisingly, there are many, many different modes of presentation. And our research has been able to understand things like cirrhosis-associated immune dysfunction that increases the risk of infection, to understand how it is that that ascites develops, why the bleeding happens. And for each of these, we've developed pathways and treatments so that we can treat that specific mode of decompensation. But ultimately, they've all happened because the liver is injured. And when a person comes in, there's an awful lot that we have to support. Patients with liver disease are at risk of bleeding, as I've said. They may have kidney failure. Their heart may not work so well. They may have problems with fluid in the wrong place, meaning they're unable to breathe easily. They need nutrition. And so lots of patients with decompensated liver disease would benefit from high dependency or intensive care level treatments. But what we find, and what we did find actually about 10 or 12 years ago, is that there was a sense among certain clinicians that people with liver disease had a futility about them. In other words, because the liver is so important, that people can be so sick that it may not even be worth trying to put people through the ITU. And a lot of work was done. Some of that was around the time when one of our consultants here at the Royal London, Michael Glynn, was the National Clinical Director for Gastroenterology and Hepatology. And we recognised that what we needed to do was identify patients early in their admission, discuss them with the ITU, and make sure that everybody had a whirl on the ITU to see if they could at least have a go. And now what you find is that that's definitely part of the algorithm. So the treatment is changing. But anyone who's looked after a patient living with liver disease or being really unwell with liver disease knows that you can do all of this stuff. But what we can't do yet is support the liver itself. So the best you can achieve is to support everything else and allow the liver to recover. Attempts to have dialysis machines made for the liver, albumin dialysis, attempts to develop new medicines, they haven't really worked. Stem cell therapies are working, either direct stem cells or maybe giving immune-based therapies are also helping, but that's all very, very experimental at the moment and only being conducted in a few centres. But at the moment, that's the state of play. We know an awful lot about what the liver does. We know an awful lot about how the liver fails. But as yet, short of transplantation, in other words, having an operation to take the very diseased liver out and replacing it with a liver from somebody who's passed away of something else, we don't have an option. And of course, transplantation is not a sustainable option. We do what, about 1,100 transplants a year in the UK, and many times more than that, people needing with advanced liver disease. So surely the best approach is to prevent liver disease from developing rather than wait until it has developed and then try and do something about it. You know, variably attributed to either Erasmus or Benjamin Franklin, the maxim that, an ounce of prevention is better than a pound of cure or something like that. But I think the principle is certainly true, isn't it? And I would argue, and maybe I've said this, and I think it is a bit extreme, but it's not a bad mantra for those of us who are clinicians, is that actually every person who comes in with decompensated liver disease or a liver cancer as a result of end-stage cirrhosis is a failure of prevention. And that's where I would like to see our focus. So for the last the second half, let's say, how am I doing for time? The second half of the lecture, I want to talk about what are those causes of liver disease. Perfect. What are those causes of liver disease? Because if we know the causes, then we can do something about them. So essentially what we're asking when we say what are the causes of liver disease is what is it that takes a shiny, smooth, healthy liver that's perfect in every way apart from the fact that it's not in somebody's body and turns it into a hard, knobbly, cirrhotic liver like this. And I guess you could probably answer that. And you probably know that one of the most common causes is alcohol, so alcohol use disorder, viruses like hepatitis B and hepatitis C infection, toxins, lots of drugs can cause chronic liver disease, and fatty liver disease, now called steatotic liver disease, and we'll come on to that in a bit. Your immune system can be overactive and can react against the liver. You can have inherited conditions of iron metabolism, copper metabolism. There are various inherited enzyme deficiencies that can also cause liver disease, but these are the main ones. So alcohol. Who knows what these are?
Hogarth.
These are the Hogarth prints, Gin Lane and Beer Alley. So alcohol and its associated societal impact have been with us for a long time. I mean, alcohol has been a necessity before it was anything that anybody enjoyed, when water was too dirty to drink. But of course, the beer that was brewed then was maybe, 0.5% strong, I suspect, something like that. But over time, alcohol has increased in terms of its usage and its impact. And part of that, we don't like to admit it, is that we are simply subjects of marketing. There's the apocryphal story that some sort of smart wag walked into Procter & Gamble as a graduate and said, well, look, I reckon I can double your sales of shampoo in 3 words. And they said, what was that? And they said, oh, rinse and repeat. So apparently there's no real reason that you have to wash your hair twice. Okay? If you wash it well the first time, you don't need to wash it twice, but you use the shampoo at twice the rate. So guess what? We now get served alcohol in larger receptacles. You walk into a bar after this and ask for a glass of wine, you'd have to specifically ask not to be given 250 mils, right? That's 1/3 of a bottle of wine. Any of you who hang out in antiques places, and I can't quite see everybody stepping forwards, but you'll see that 18th, 19th century wine glasses are tiny. So the idea is that in order for us to consume more, we've been sold more, and the alcohol has got stronger, okay? So one way to tackle this could be to put a minimum price on each unit of alcohol. And you don't have to make that astronomical. You don't have to price everybody out the market. But what you might want to address is those multi-offers, getting the loss leaders that allow us to buy lots and then get into it and create those habits, or the super strong stuff that nobody really drinks for pleasure, but unfortunately people who live with alcohol use disorder might need in order to fulfill their cravings and all the issues that have come around. And if you look at applying a minimum price per unit, you can see what the cost is. So a bottle of whiskey, most whiskies are much more than that anyway. That's quite a lot, but I mean, even so, most spirits are more than £13. You wouldn't need to charge more than £1 for a can of lager, but this stuff would have to be over £11, okay? So in other words, what you're doing is trying to change behaviour for the if you like, the starter, the easy pickup, high alcohol drinks. So what happened? Well, if you ignore what happened at the pandemic, where, I can tell you anecdotally, in 2020, 2021, towards the end of 2020 and 2021, the acuity, the severity of liver disease that came through the door here at the Royal London went through the roof. We were seeing routinely 20, 25 patients with decompensated liver disease. We had lots of those patients who were on the ITU, and it's because a knock-on effect of the lockdown was that we had lots of people drinking an awful lot more. But just before then, when the Scottish government had implemented a minimum unit price, you could see that there was a dip in alcohol-related deaths, but also there was a dip in alcohol-related admissions to hospital. And we wait to see what the results of after the pandemic. But clearly there's been an impact. New Zealand have implemented this, Canada have implemented this, England and Wales have yet to do so. Alcohol-related liver disease also teases out another factor that actually the pandemic, I would say grudgingly, brought out, which is that there is a huge disparity in outcomes based on deprivation. Okay? So if you look at mortality rates for people in the least deprived group, they are much, much lower than mortality rates in the most deprived group. And that difference is most stark in alcohol-related liver disease. So I think when we're tackling alcohol-related liver disease, absolutely we want to make sure that everybody has a chance to get to ITU. We want to make sure that we do know how to look after people in the hospital setting. The research should be focused at developing newer and better ways of researching liver disease. But the battle is fought and lost at this stage in the community. Let's move on to hepatitis C. So I looked at this. This was written 2 or 3 years ago, the remarkable history of the hepatitis C virus. Now, the history and the fact that hepatitis C is now history in itself is remarkable. Hepatitis C is a pandemic. It is a virus that affects around 250 million people worldwide. Okay? It is a major cause of liver failure, cirrhosis, and liver cancers. And in 1978, it was established that there was a condition called non-A, non-B hepatitis that was transmissible. So we figured out that this was something that could be given from one person to the other. In 1989, they cloned the virus. In the mid-90s, so just a few years after it was discovered, we started using an injection called interferon. Interferon is the stuff your body makes when you've got the flu. It's the stuff that makes you feel achy, tired. And guess what? If you inject millions of units of this stuff into people, they also feel very, very tired. Response rates down at 6%. Okay? We learnt what to do with the interferon, how to treat it, add in more medicines, do stuff to the chemical so that it hangs around for longer in the body. But we were even at the peak of doing the best we could, we were hitting around 1 in 2. So you treat somebody for a year with an injectable, it's terrible, and they've still only got a 50-50 chance of curing the virus. Now, I'm aware of the fact that this is very much like trying to explain to my children what life was like before a mobile phone, and actually having to turn up somewhere where you were supposed to turn up. All very interesting, but actually entirely irrelevant to their lives, because now patients who walk into the clinic don't really need to see me. Essentially, if you have hepatitis C, you can have a tablet that you take for 8 or 12 weeks and effectively cures everybody. And in 2020, these three won the Nobel Prize for discovery of hepatitis C, its structure, and the drugs that were developed as a result of it. These are the trial data. So these are the 2 main combinations of medicines that we have. And you can see that 97 to 100% of people are being cured. And unlike pretty much any other field of medicine, what we saw in the trials is actually what we see in the clinic. The argument now is that you don't even need to test people afterwards to make sure they've cleared. There's no point in having a great drug if no one can get to it. And the big challenge with hepatitis C, like with all liver disease, is that you don't know that you've got it unless you test for it. And so we have to go out, we have to find people at risk, and that initially we went into the drug treatment centres, we took the treatments to the drug treatment centres, we went to the prisons, we went into the community centres, and then we started to find people who have hepatitis C. And obviously, now it's getting harder and harder to find people because we're treating more and more people. And this is a win for our local university, our local hospital. A lot of the work, particularly in the hard-to-treat genotype 3 strain of hepatitis C, that predominantly affects people from Pakistan and from Bangladesh, but particularly from Pakistan, was spearheaded here by this man, Graham Foster, who actually this month retires from clinical practice in the NHS, and who I was, who's been a mentor to me for the last 20 years or so. And he led some of the international trials that proved that the drugs worked really well in this genotype. He also conducted community studies here in the East End of London to go and find people with hepatitis C and develop strategies for that. And with a grant from the very prestigious Wellcome Trust that most scientists would build a career on. His retirement win was to win a £3 million grant from the Wellcome Trust to take this into Pakistan. And not only that, but now if you turn up to an emergency department accident emergency in a London hospital, unless you opt out, you will be tested for Hep B, Hep C and HIV. So we're finding people with these transmissible diseases. We are curing people with hepatitis C. We're feeding people with hepatitis B into treatment programs so they don't develop the complications of liver failure and liver cancer. And I can tell you that, again, we're talking about the lifetime of a career. So when I started as a registrar in 2006, so I used to say that like it was only recent, but now I realise that's actually ages ago. But anyway, the wards, the Old Mary ward and the Old Royal London Hospital was full of young men, usually from Africa, who had hepatitis B undiagnosed and were presenting with cancers. But now we just don't see that anymore. Because as soon as people are diagnosed, they're put on medication, they're monitored. My colleague Patrick Kennedy looks after them in his clinic with his fantastic team. And this is not just here in London, but across the UK and anywhere that's got a hepatitis B treatment program. But we can prevent those things happening. It goes back to prevention. So people wanted to know a little bit about me and how I got to where I got to. So I trained in Cambridge. This is Downing College, where I was very lucky to go from. I was at school in the Midlands in Leicestershire, and I went to Cambridge and I did the MB PhD program, which meant that I could do a PhD alongside my medical studies. This is, the fact that you're putting up a picture that looks like this does make me feel really, really, really old. But this is 1998. I can't believe I'm that guy. 1998, the Part 2 pathology, when I had a lot more hair than I have now. And then that's me getting my degree, and that's who's the master of Downing, that's David King, who some of you will know was the chair of the Independent SAGE during the pandemic, a really lovely chap. Okay, anyway, that's me. And having been through that path, and I did my PhD early, probably earlier than most clinicians will do their PhD, I benefited from a wonderful scheme we have in the UK. I don't think we're as proud of it as we should be. I don't think we're as vocal as to how brilliant it is compared to other countries. Other countries simply don't have this, which is that you can have time within your clinical training to dedicate to research so that you can either build up towards a PhD or from a PhD build an independent research career. And I was a beneficiary of both of those. Now you can start things a bit earlier. The MB PhD program, Cleo Bishop and myself have set up an MB PhD program here at Queen Mary. And we recognise that we've got a lot of people who go into an independent career but still need support, and therefore what I've done with colleagues is set up a clinical academic training school here so that we can support people throughout this clinical academic training pipeline and hopefully continue to feed in people who are going to research in this space. And there are various benefits of this, but really it's the joint support of the Trust and the university that's enabled us to do this. I can tell you a little bit about my disease, steatotic liver disease, so fatty liver. There is an excess of fat that builds up in the liver, and I'm going to skip over that. And it builds up, and in some people that causes significant liver disease. And it's associated with obesity, and we can see here adult rates of obesity, the darker the colours. And can you see here, there's a hot spot in the East End of London. This is our problem. The bit that worries me more than anything is how many of our children are obese or live with obesity and overweight. And this is by London Borough. You can see here the big hotspots. You've got Newham, Barking, Havering and Redbridge, but Tower Hamlets isn't far off. This is year 6 children, 10 and 11-year-olds. And we're talking about over 40% of those kids living with obesity already. And we do have high rates of metabolic disease in East London. Others before me have shown this both in terms of diabetes and obesity, heart disease, and guess what? We see the same in liver. And I think we've got our own set of risk factors. You know, I think we talk a lot about alcohol, but we need to talk an awful lot about sugar-sweetened beverages, high fructose corn syrups in lots of these sort of drinks that have never seen a living creature in its life, but we drink lots and lots of them. Tim, you've heard me talk about this before. A lot of the chicken and chips shops will have specific offers for, like, you're going to get a box of chicken and chips for £1 or £2, but only between 3 and 4 in the afternoon, targeting kids who are coming out of schools. I think we need to do better from our planning laws. All right, so we have a lot of metabolic disease in East London. And that translates into less healthy lives. So the concept of healthy life expectancy means that when you're born, how long can you expect to live before you start having significant disease? For a woman who lives in Richmond upon Thames, that is 71 years of age. For a woman in Whitechapel, that's 59. So that's 12 years of healthy living lost simply by their demographic. Put it differently, you start in Westminster, you lose a year of life for every stop on the Jubilee line east. Okay? So the disparities that we see are, I mentioned them in alcohol use, but actually in terms of metabolic health, these are really evident, and we see them in our city. For that reason, we set up something called the HARP program. This was mainly funded by the Wellcome Trust, but also our local charity and local partners, looking at health advances in underrepresented populations and diseases. So we've got 32 PhDs over 5 years studying research questions that affect underrepresented people. I'm going to whip through some of these slides because we're getting a little bit technical and I want to move on to a concept. So the first thing to say is that you've seen what the rates are in East London. Around the world, we estimate that around a quarter of the general population has got a fatty liver or steatotic liver disease, and that rises to around 2/3 of people living with diabetes or 3/4 of people living with obesity. But 2/3 of people living with diabetes aren't dying of liver disease, okay? That's not the main reason why people with diabetes end up in trouble. The reason is that this is a spectrum of disease. So the vast majority of people sit down here. They have a fatty liver, they have risk factors for heart disease, but they're not going to develop a liver problem. It's a smaller proportion, maybe 1 in 20, but still 1 in 20 of a high percentage of the population is a big deal, will develop the advanced fibrosis and the cirrhosis that we're talking about. So what happens to people living with fatty liver disease in Europe? Well, I led a study a few years ago now, looking at 18 million European adults, looking for people diagnosed with fatty liver disease. Although you can never be too sure what's going on, we knew that we'd found probably the right people. Look, higher percentages of people with obesity, higher proportion of people with diabetes. And the main risk factor for those who develop cirrhosis and liver cancer is diabetes. So diabetes and fatty liver disease go hand in hand, okay? In fact, it was intended uncharitably, but I think accurately by one of your predecessors, in fact, Tim, as director of the institute, that essentially fatty liver disease is just diabetes in the liver. Well, I think actually it is diabetes in the liver. It's just understanding who's going to run into trouble. And the people that run into trouble, now this graph shows you the number of survivors after a period of time. This is in years. So as the curve goes down, more and more people are dying. And the people that are dying are the people with the inflammation that I talked about earlier, the scarring, and the more scarring there is, the more likely it is that they're going to die from the point of diagnosis. Now, you've got to think about that a little bit, because if you take 2 cars that are travelling down the motorway, the one that's going to get to its destination first is the one that's driven the furthest already. All right, like we call that lead time bias. But nevertheless, people with fibrosis, with scarring, are the ones that we need to focus on first. So how can we detect people who are in this box? Because there's stuff that we can do. We can look at their risk of progression. We can survey them for complications and pick them up early. But as I have said, the amount of scarring and the amount of function lost are not correlated, and we can't easily measure that clinically. So we start to think, well, what do we know? What does the science tell us about this condition? So we know that I've talked about inflammation and immunity. We've talked about diet and the environment. Ethnicity is a big factor. We know that people from our own work, our own research, that people of South Asian ethnicities tend to get this disease about a decade earlier and at lower body mass indices. We know that the genetics play a role. But these don't really feed into something that you can easily test for in a clinic. You can do a liver biopsy, okay? Very common procedure. We take lots of local anesthetic under the skin, pass a very thin needle through the skin and take a tiny slither of liver tissue, try saying that after a drink, and look at it under a microscope, okay? But obviously they won't let me stand on the Whitechapel Road and just biopsy everybody as they come out of the market. They didn't like that. Oh, this is being recorded, I've got to be careful. So let's not want to do a biopsy on everybody, obviously. What about a simple test? The answer is there are some tests that we can do. We can do a score, we can do a sum. So we can get our calculator out and we can measure 2 simple blood tests that relate to the liver. We can measure the number of platelets that are circulating in the blood, put the age in, and we get a score. And what's good about that score is we can split this survival curve so that people on a high-risk trajectory can be identified based on their score. That seems reasonable. We can do a scan. This is me doing a FibroScan, just to prove I do some clinical work from time to time. And essentially, this goes back to that stiff liver, the liver that's no longer supple. This machine will simply flick the side of the skin and listen and see how quickly and how loudly those sound waves come back and make inferences based on those parameters. And so if you do a score, we call it the FIB-4 score. If you do a score, because it's got 4 parameters, and then you do the scan, okay, you can start to separate out people really well. Look, this group of people who are sadly dying more rapidly, they're the ones who had a high-risk FIB-4 score followed by a high-risk FibroScan score. So I'm going to flip it over here. So the tools are available. The problem is they're not yet used. And I think they're not used for a number of reasons. One is familiarity, okay? This is not that straightforward. It's not that widely known about. We need to do better at disseminating the information. We need to make sure that colleagues in other disease areas are confident to use these tests. But also, there is a sense of so what, as in we don't specifically have treatments yet for this condition. I'll come on to that in a moment. So it seems that if there are human factors that are getting in the way of testing, can we automate it? And that's exactly what we've been doing in the Prelude 1 study. We've added the FIB-4 score to the diabetes annual review. Everyone with diabetes goes to their GP once a year for a checkup. All sorts of things are checked. So we've added the FIB-4 score. And we're testing to see whether or not it's better to have that scan in the community or get referred up to a hospital. And a spoiler alert, we've just got some data in. We've only just submitted it yesterday. I can tell you that you are much, much more likely to turn up to a scan and have it if it's done in your GP practice, rather than dragging you up to the hospital. So what I would like to do is to get everybody to ask their GP, ask their health provider for their FIB-4. So ask for your FIB-4. I had this idea on the train this morning. I've already emailed the team, and actually, amazingly, they've already come up with an idea as to how we can have a campaign. So watch this space. No treatment? Well, not quite. Weight loss certainly improves your liver fibrosis. Here's a study that they did in Cuba about 10 years ago now. If you lost more than 10% of your body weight, okay, then you had an 80% chance of reversing the fibrosis. So the fibrosis is going back down again. The problem is losing 10% of your body weight is incredibly difficult to achieve and a lot harder to maintain. And in fact, around 5% of the people in this study, 1 in 20, were able to do that. So here is a dartboard of all the medicines that are being trialled in this space to try to treat fatty liver disease with fibrosis. And I've got a wonderful set of colleagues in my nursing team who help us recruit patients into these trials so that we can bring those medicines, learn about them. Patients living in the East End of London are able to access these medicines. And again, last week, so this time last week, we heard that the FDA, the Food and Drug Administration of the United States, has just licensed the first of these on an interim basis, waiting for further data, but showing that around 30% of people the NASH, the steatohepatitis, the inflammation will go away, and around a quarter of people who take this drug for a year, the fibrosis will improve. Okay? I'm going to move on, but I do want to just say that one of our clinical lecturers, so one of our trainees here who's now got a PhD and is moving towards independence, led an audit of practice around the UK, showing that there's a big gap between what we led this here from Queen Mary, what we see as the quality standard for care of people with steatotic liver disease from what happens now all around the country. Now that's a really important bit of data because that's a starting point. That's where we start to realise where those disparities are and what we can do about them. So what are we doing here at the Royal London? Well, we have a pathway, in other words, a sort of a set of tests or a set of rules to help people in GP practices manage patients living with steatotic liver disease, and that includes assessing their risk of heart disease. We've got joint leadership of our liver and our diabetes clinical teams. That's me. I'm the interim clinical director looking after both of those specialties. We've got a regional one-stop diagnostic liver clinic where you can see a nurse, a dietitian, get your fibroscan done all at one go. We have a multidisciplinary team that looks after patients with steatotic liver disease, and we run the trials here as well. We're interested in the genetics. There are lots of other talks in Centre of the Cell around genetics and how that's helped, and particularly the Genes and Health programme. And what we're interested in is whether knowing somebody's gene risk, their genetic inherited risk, can be used to refine, i.e. get a bit more granularity on what that FIB4 predicts. So this is work that's ongoing with us in the group. Ritvika Malik is starting to work on this with the Genes and Health team and with Graham Hitman as well. And Raju is here in the audience, and Raju and Wenhao have been studying patients who have surgery to treat their obesity. And at the time of surgery, these patients have allowed us to take samples from the liver, the fat tissue, and the blood so that we can learn more about those inflammatory cells. And that's work that's ongoing. But in order to study human disease, we need the help of patients and the public. We need the support of patients and the public to tell us if we're asking the right questions, and if we're not, put us back on track, but also who are prepared to volunteer to take part in our studies. So this is Jill Hood, who leads a wonderful team of nurses and research practitioners. She looks after the diabetes lay panel, people living with diabetes who've kept us on track over time. And this is John Loy, who's a brilliant surgeon, but also an absolutely superb collaborator over at the Homerton, with whom we've been working for many years. And the confidence in this space is shown by Bart's Charities investment in us. And we've set up Bart's Metabolism Network to understand more, not just about liver disease, but also about metabolic disease. So I hope what I've done over the last 45 minutes or so is take you from pointing out where your liver is, all the way through understanding what happens when it goes wrong, why it goes wrong. And I hope what I've also done is start to persuade you that actually it's the prevention piece where this will be fought and won, rather than waiting for decompensation. Whereas we certainly need, until that happens, to have better treatments and more effective care for people with end-stage disease. Thank you very much for coming to this lecture.